Good morning, everyone. Good morning, everyone. Welcome to the session. My name is Harry Marwa. I'll be the moderator for this session. The future of healthcare is digital, harnessing the power of connectivity and data for UHC. The session has been organized by PharmAccess. PharmAccess is a Dutch NGO. We work in 4 African countries with our headquarters in Amsterdam. For those who have been following the United Nations General Assembly meeting, you will agree with me that one message which was clear during the discussions was that most of the countries, especially in sub-Saharan Africa, are far behind the target of achieving UHC by 2030. And actually, it is also clear that if we continue with the same pace, it will be almost impossible for these countries to achieve UHC by 2030. While we observe this lagging behind in health sector, we see other sectors are transformed with the digital developments. For example, if you look at what is happening in the area of the financial sector, you realize that a lot of changes and access have been supported with the development in digital. However, we don't see that happening in health. And that's why we believe digital transformation can also be a key if we want to achieve UHC by 2030. I'll share with you 2 cases just to start our discussions for today. For those who can see there, the woman you see on the left is my mother. She's living in a village there, which is written Komuge. She's hypertensive, so she had to access her medication every month. But to do that, she had to cross Lake Victoria with a ferry to go to Msoma, as you can see in that slide there. So I keep asking myself, if I can order a laptop from Amazon and receiving it here at Dar es Salaam, or if I can order a diary from China and receive it in Dar es Salaam, why she cannot order medicines and get them at the village where she's living? She had to use 2 hours to cross Lake Victoria to get the medications. Again, I just spoke about how other sectors have been transformed with digital. We all know the power of the debit or credit card. Today, you can even be at Goma, one of the areas with serious security concern. You can be in Ukraine, you can be in Russia with your debit card from a bank in Tanzania, and you can access your money while you are there. I know we take it for granted, but I'm not sure you have ever thought or think like the information which has to be exchanged between the banks for you to access the money from different bank, different ATM machine, different country. I'm sure if I give you option at a gunpoint to decide whether to share with me your bank information or your medical information, you will probably opt to give me your medical information. But why, if I'm treated at Muhimbili Hospital and get referred to Muhimbili Orthopedic Institute, MOI, or JKCI, just 200 meters apart, you cannot access my data to other facility. I have to start all investigations again. And that I'm not even talking of data from Kigoma to Muhimbili or from Amana Hospital to Muhimbili. I had a case where my brother had to do 3 CT scans and 2 MRI just because he had to be referred from Bukoba referral to Bugando to Muhimbili within 2 weeks. Someone had to pay those costs, and sometimes it can cost life. So how can we harness the power of connectivity and data to achieve UHC? So I have a list of panelists who will share with us the initiatives. And to start with, please allow me to invite John Method. John is a pharmacist, graduated at Muhimbili University. He's co-founded and worked with two successful digital health innovation startups that aim at improving health of the community. Currently, Method is operations manager at PharmLinks, a digital innovative company that is transforming the supply chain of pharmaceutical products in Tanzania by using technology. Please welcome John Method.
Good morning, everyone. It's a very great honor to be here today. And as Dr. Eri introduced me, my name is John Method. I'm a pharmacist by profession, and currently I'm working as the operations manager at PharmLinks, a digital and innovative company that seeks to improve the health of Tanzanian community by using technology. And our main goal is to increase the access of medicines in our country. And we are doing that by using technology. Yeah? And for us to increase the access of medicines needs to move from one entity to another. Let's say you're in a pharmacy, you're at the hospital, or anywhere, those medicines need to move from that facility to you. And those series of steps, when medicines move from one entity to another, are called pharmaceutical supply chain. And pharmaceutical supply chain is a very complex chain of activities. And that is because of 2 reasons. The first reason is because of the number of stakeholders that are involved in that process. Medicines need to be manufactured from the manufacturers who are usually located in maybe Europe, India, and countries like that. And then they have to go to the importer, who will import them in the country, and then the wholesaler, retail pharmacy, hospital, and finally to the final consumer, who is the patient. Yeah, and also because these medicines are very special goods. They're not like clothes or watches. They're very important that there are policies, rules, and regulations in place to ensure that the quality is not compromised when these medicines are moving from one entity to another. So all these things contribute to the complexity of this pharmaceutical supply chain, and it leads to the emergence of different problems in the access of medicines. If you can look at the screen on the left side, there is a tricycle which summarizes the problems that come when these medicines move from one entity to another. On the top part is prices. When these medicines are moving from one point to another, these players, the manufacturers, the importers, the wholesalers, the retail pharmacies, the hospital, usually add margin on top of the prices. And these contribute to the increase of medicine prices to the final consumer. So they do this maybe because they want to compensate the operational costs that they incur, but sometimes they do it because they can. you know, you have medicines, you just add 10%, then you sell, you make more profit. On the other hand, this problem hinders the availability of medicines to the final consumer, who is the patient. And also, because these systems are not interoperable and sometimes they not see each other, they can lead to compromise of the quality of the medicines. And the overall effect is that only a fraction of population can have access to quality medications and actually afford it. So this is what we're trying to solve. And PharmLinks is the digital platform which is transparent, competitive, and efficient marketplace for pharmaceutical products. So what we do is that we have a digital platform that links suppliers and retailers of pharmaceutical products, and as well as the facilities like hospitals and polyclinics. So in our platform, we have suppliers of pharmaceutical products who have the stock in terms of pictures. It shows the generic names and the prices at which these medicines are sold at. And then these retailers can access via their mobile phones and computer devices and see which supplier has which products and selling at what prices. So as you can see on the right part of the picture, we have a number of players who are all centered around our platform. First, we have importers. We usually prefer to work with importers because usually they have lower prices. And as I said before, that our main goal is to lower the prices to the final consumer. And also we have the logistics service providers, because once the order is made, these medicines need to move from the supplier to the final consumer. And also some other financing partners like insurance companies and the medical credit funds. They can be in our platform and increase the access to medicines in the platform. So the overall effect is that we increase availability, and capture information in terms of data which can be used to inform the decision making in our governments, as well as make predictions and be prepared when these things change, like crises and stuff like that. So that is a summary of what we do in PharmLinks. I don't want to take much time in this first time. We'll discuss more during the discussion, and I hope you can ask questions and answer them accordingly. And thank you very much.
Thank you very much. Our second presenter is Adelaide Kiliba. Adelaide is a professional software engineer and a certified project manager, currently working as a CEO of Tanzania ICT consulting firm called GPITG Limited, which is dedicated to develop, customize, deploy, maintain, and support electronic information platforms in the continent of Africa. Adelaide has tremendous knowledge and experience of more than 20 years of working in USA and Tanzania. Please welcome Adelaide Kiliba.
Good morning. I think I really like what John was presenting, and maybe I'll ask him to meet with us later on to see how we can both connect together and find a way to incorporate our systems. I like the fact that he's managing the stock before it reaches our clients. So when our system, which I'll go present here shortly, works with John's platform, I think it will be able to improve some more efficiency in terms of stock management to our clients. Like Dr. Harry had just introduced me, my name is Adelaide Kiliba. I'm from GPITG, and today we'll be presenting you one of our platforms that we know and has been our dream to see what we are presenting here today, the harnessing of data connectivity, data movement within the country. Because we also know without that, there's a big danger of continuing the same way of having very poor healthcare delivery in the country. And us, as the coming from the ICT background, we know we have something that we can offer into the healthcare industry to enable the whole improvement of healthcare delivery and the whole improvement of healthcare in the country. So the platform is called EHMS EHR, in short of Electronic Health Management System. It is very comprehensive. By the way, it's the oldest in the country. We've been managing this platform now for over 10 years, growing and developed within the environment of the continent of Africa. And we thank God today we have a number of clients in Tanzania. We are starting Kenya, and also we are starting in Sierra Leone. The EHMS ERP comes with components of the electronic medical record, meaning the processes of managing patient care from the time patients arrive at the hospital until they check out for outpatient, inpatient, emergency, and mortuary. So the whole facility become paperless. All the operations become paperless and has shown to improve a lot of efficiency for the delivery of care for visiting patients. Part of the EHMS ERP comes also with the support business processes, issues that according to the e-health standard guideline by the Ministry of Health, whereby you have the core platform, the triage, the reception, doctor's page, pharmacy, laboratory, and that. But then there's also other supporting services like appointments, CSSD, any other processes within the hospital is part of the component of the EHMS EHR, but also the accounting and finance components of that. So at the end of the day, a hospital receives a complete picture in terms of the financial part of the movement or the care of a patient, both in the credit sector, in the credit section, cash or exemption. So at the end of the day, the whole reporting, the trial balance, income statements, balance sheets is also part of the EHMS EHR, but also human resources and administration as part of managing the employee, the team from hire to retire, the performance of the employees, performance of the departments is also part and parcel of the system, and most of these functions, they happen automatic. So every department, they just build their KPI, doctor just does his work, pharmacist does his work, laboratory does his work, nurses, at the end of the day, all the KPIs, they are built automatic, and at the end of the day, even it becomes easier to do the appraisals. Okay. Sorry, I have short time. So at the end of the day, the whole story, like I said, it becomes completely paperless, and it is very integrated platform that we believe having, like I said, integrated to other solutions will be able to harness the whole issue of connectivity and building the movement of records from one facility to another. At the end of the day, to get the complete reporting at the higher level, it's going to be a lot more easier. We have over 85 hospitals using the EHMS, the likes of Bugando, KCMC, Amana Regional Referral Hospital, Dodoma Regional Referral Hospital, Mount Meru, and many other facilities. Around 85 plus are using the EHMS to date. That is in Tanzania alone. Thank you so much.
Thank you very much, Adelaide. My third speaker is Shilton. Shilton Olomi is a CEO of the Innovestia Limited and the founder of MyHI. He is driving the real change in insurance sector with MyHI. Shilton is working diligently to make healthcare insurance more user-friendly and improving the process to make them more affordable every day. His down-to-earth approach and commitment to deliver tangible improvement in insurance and healthcare have earned him a reputation as a practical and result-driven leader in the industry. Please welcome Shilton.
Hi everyone, it's my pleasure to be here. Thank you, Dr. Henry, and the team for inviting me here today. And I would like to talk more about MyHI and health insurance perspective in Tanzania. As we all know that we have the goals of increasing inclusion of health insurance and insurance at all and reach the target at least by 2030. But this goal we have, we won't be able to achieve it without including the power of digital and data. As we all know that in here, we all know about what does it mean or what insurance is, but how to access it, it's still confusing. Right now, there is several initiatives and several ways that people know that we can have access to a health insurance, but we don't know the products. We are afraid about, we might spend a lot of time on the process of obtaining the health insurance. And also, we don't know if the plans that are existing maybe will cover the needs we have or not. And also, the mindset we have that it's health insurance, it's still expensive for most of us to have it. And also, what we're afraid of is after having insurance, when we go to the health centers, hospitals, the priorities that healthcare providers are giving us as the people who have insurance still is not good enough for us to pay and depend for health insurance only. So there are several problems in the health insurance sector that all of that needs to be solved. And in solving that, at MyHI, what we're doing is initially we want to make better access to health insurance and improving the customer experience, and also want to make better plans, personalized, and also providing this insurance at low cost, but also want to achieve the better healthcare goal. So what we have done now is we've created a platform whereby a person who needs an insurance or who want to know more about health insurance will download the platform and read about the plans, maybe compare the plans, and after that, you'll be able to do KYC and make payment and receive an insurance instant on his mobile phone. But our plan is to leverage more on data and make the plans which cater the specific demands of different demography in our society. So we want to make health insurance better on that side, depending on data and what's really happening in the society. But also, first today I'm thankful that you've met my other colleagues who are working on other value chain, like components in value chain of healthcare, and also leveraging technology. Because as we're approaching UHC, it's almost impossible to provide, or this current provider, to provide the health insurance plans that all people will be able to buy. Why? Because the value chain, it's broken down. Healthcare providers operate on their own margins, insurance companies operate in their own margins, brokers operate in their own margins, medicinal importers and distributors are working on their own margins. So a simple example, if I'm importing Arthmeta medicine, the distributor price for that a dosage of Arthmeta it ranged from 300 Tanzanian shilling. But when you go to take that medication of arithmetic injection in the normal hospital, it costs 30,000. So there is, I hope you can see the price increase on there, from 300 Tanzanian shilling to 300,000. So, okay. So for now, to link or to provide this affordable healthcare and affordable plan to achieve universal healthcare, for current model, it won't be achievable. I can say that because the whole system is broken down. So at MyHI, apart from bringing the access of health insurance, we are also working that to make sure that our end goal is we provide the better healthcare in the whole healthcare value chain. Thank you so much.
Thank you very much, Shilton. My next speaker is Florine Modamba. Florine has more than 15 years of professional working experience in different sectors, including financial and banking. So we really need him to get the experience from the financial sector, telecommunication, and health sector. He's a co-founder of AfyaCall, a company focused on developing and providing healthcare solutions in Tanzania. And for your information, AfyaCall is the first company in Tanzania to provide telemedicine services, whereby mobile users across the country can obtain 24 hours live doctor's consultation via their mobile home at home. He is currently serving as AfyaCall CEO. Please welcome Florine Modamba.
Ladies and gentlemen, good morning. Thank you very much, Dr. Harry, for the introduction. And I think I will move straight to the topic to save the time. As he said briefly, Florine Modamba is my name, working with AfyaCall as the MD currently. I have a background in finance. I have worked with the telecom. So together with my colleagues, I'm a co-founder of AfyaCall. We sat down and came up with an idea of bringing up a solution called AfyaCall Daktari Kiganjani. As you can see there on the screen, what AfyaCall is doing is basically to support the main theme that we have today. The future of healthcare is in digital. What we need to do is we need to take advantage of connectivity and the use of data to provide the service. AfyaCall is bridging the gap and taking advantage of connectivity and the use of data combined with the technology, the IC technology, to deliver the service. So as I said, AfyaCall is a solution providing service to mobile users in Tanzania, popularly known as telemedicine. What we are currently doing, we have 24 hours live call to doctors, which allow all the mobile users located across the country to have an opportunity to access the doctor's services anywhere, anytime. We also have SMS health tips that people can access for education purpose and awareness. We also use IVR. IVR is interactive voice response. Those are the main services that we are currently offering. So we are targeting providing advice and education in terms of awareness through SMS and IVR. The objective is to drive the use of mobile phone in bringing healthcare services to people in Tanzania. We want to increase inclusions in the universal health care. That is our goal, to make sure that there is an inclusion. The objective also is to create a healthy community. When you have a health community, that means you have a productive human capital, and those are the people who can help in the development of a country. Our focus in terms of area, currently we are covering all regions in Tanzania. And in terms of reach, we have a reach of over 15 million subscribers, our mobile users in Tanzania. In terms of what are we targeting to deliver and what impact do we want to create, we want to create a health community through availability of healthcare through the use of technology, the telemedicine. Telemedicine, basically, in simple terms, for we all know, is the use of ICT, the information and communication technology, to provide and give support in the healthcare. So the use of technology assure availability in terms of cost. Our model is very low. Right now, we do provide access to doctors' calls up to a minimum of 1,000 shillings, where you can have 5 minutes. 1,500, you can have 10 minutes talk time to the doctors, and with 3,000, you can have half an hour talk to a doctor, a professional doctor, so regardless of where you are in the country. So in terms of consultation, you can see it's a low cost in terms of the model. And then you have accessibility also in terms of technology is assured, and then also convenience, it's anywhere, anytime. So as you can see, it's live call, SMS in terms of education, you get consultation, and then SMS and IVR, you get educations. We also engage other partners in delivering this, because we know pamoja tunaweza. We are working with Vodacom Tanzania, so we have partners with Vodacom Tanzania. So basically, we have all Vodacom subscribers have access to the service. It's optional, it's available. We are also working with PharmAccess in a project called Jali Afya in Zanzibar. It's a community-based project where we are supporting people with NCD through the use of digital. They can get support and monitoring remotely. So basically, who are we targeting? It's everyone, all people, youth, mass, both with the feature phone, the Kitochi, plus the smartphone, but also we have a special bullseye target, the elder people, the pregnant, and the children. So that is what we do. And in terms of impact, we can all have, currently have an average of 1,800 users accessing our live calls online, and almost 10,000 users using our SMS and IVR calls. Thank you very much. Pamoja tunaweza.
Thanks, Florin. I'm sure I'll have enough time during discussions to clarify more. Very interesting presentation. Last, but definitely not least, I have someone who tried to combine it all. She has experience of nearly 15 years working in various sectors, including customer service, partnership management, insurance, product management, and others. Currently, she is working as head of innovations at PharmAccess. Please welcome on stage Zamaradi Mbega.
Thank you, Dr. Harry. Good morning. So as Dr. Harry said that I'm going to tie it all up together, what has been explained, but what I'm also going to explain will touch on what Dr. Harry said when he shared experience. Is he Mama Harry? Naitwa Mama nani? Mama Harry, yes. how we can help patients, including Mama Harry. And I'm talking about remote care. If you look on the screen there, some of the things we recognize, you can see the point of service for healthcare in Tanzania, where we have from community level to district hospitals up to zonal hospital. We didn't include national hospital, but you can just add it at the top. But we also have the customer journey. And if you look at this, it's more common for the diseases that require continuous and regular care. We can talk like NCDs, like maternal care. Most of them, that is the client journey. We are talking about awareness to screening, diagnosis, regular measurements, medication, as well as management of complications. That is what we envision with remote care. But if you go to the ground right now, that is not the situation. Most of the care is being accessed at healthcare facilities, and in most cases from district hospital and up. And you saw the visit. To some clients, you actually have to cross a lake to access services. But looking at it, most of these services can easily be accessed at community level. We are talking about awareness and screening. There is no need for a patient to travel just to be screened or just to get some education. There is no need for an NCD patient to go to a district hospital to collect medication. And most of them need to get these regular measurements. You just need to get your blood pressure. You just need to take your blood glucose. Do you really need to go to a district hospital to do that? That is not necessary. So what we are saying with remote care is, can we move these services that people travel to access to community level, to lower levels, so that we make it easier for patients and we make it convenient for patients to access this care at the convenience of their homes. Somewhere in the village, you don't need to go to a hospital to get your blood pressure. So can we move these services closer to people? And then we leave the healthcare facilities for when we really need to see a doctor, when we have complications, when we need referrals. That's when we go to a healthcare facilities. And this is very beneficial for the patients and for the doctors as well. If you look at WHO data now, they say the ratio in Tanzania for doctor-patient ratio in Tanzania now, it's 1 doctor per 20,000 patients. And the recommendation is 1 per 300 patients. So we definitely need to reduce the workload for our doctors to ensure that they have enough time to care for the patients that really need the assistance. And to do this, we definitely need the likes of FarmLinks. If we are talking about delivering medication, hospitals cannot do that. We need the likes of FarmLinks to do that. If we are talking about remote monitoring, people accessing services at home, we need the likes of AFIACall to ensure that data can be collected and can be transferred to healthcare facilities. And not if, when all this is successful, these are some of the benefits that we can see. People have accessed care, we have collected information, and all these providers are connected. What are some of the benefits that we can see? Who are the people that can benefit from this, other than patients and doctors that I spoke about? We can talk about insurers. Right now, we have insurers that are developing products and they don't have enough information, resulting into very complex benefit packages and very high premiums that people cannot afford. We are talking about policymakers. In Tanzania now we are talking about mandatory health insurance, and the bill has been passed in Zanzibar, and we are waiting for the bill to be passed in mainland. Do we have enough information to inform these bills? Do we have enough information to inform the mandatory health insurance? We are talking about mobile money. We are talking about community health workers. We have community health workers and they have a number of services that are providing to our people. Can we ensure that community health workers have enough information so that they can provide these services? We are talking about supervisors, DHMT and RHMT. They can also access this information to ensure that they better supervise the healthcare facilities. So in a nutshell, that is remote care, and that is how we can connect all this that we discussed to ensure that we provide access to quality health care. Thank you so much.
Thank you very much. I told you she's going to connect it all. So I'll ask a few questions, and then I'll open the floor for the audience who want to contribute or to ask any question. I really like it when Adelaide mentioned that he has seen a potential when he saw John's presentation on FarmLink, and I think I also have more or less the same from Shilton. So my first question, which will go to John and probably also others, if you look at of the dream we have, we want someone to enroll in health insurance while sitting at home, assuming MyHI, and then the data automatically goes to the facilities through EMR, which GIPTG and others, the government systems has, so that when I go to the facilities at first time, they don't have to ask my personal details and other details which are already provided to someone who enrolled me into insurance, which I did while sitting at my couch at home. And then we want the facilities which are connected with this system to access their medicine through FarmLink, and when I need a fill-up of medicine and I don't need any I don't have any complication to see a doctor, I just sit at home and I order through FarmLink using the same data which is collected. And sometimes I can test my blood pressure, and using AfiaCall platform, someone can monitor my results and call me if I need to see a doctor. So that's a big dream. Now my question to the panelists, starting with John. What has been the challenge to achieve such kind of dream? Do you think it's a technical issue or it's a policy issue or both? And how do you see that dream can be realized?
Thank you, Dr. Harry. Thank you, Dr. Harry, for a great question. Actually, UHC itself, it insists that anyone gets quality health care wherever they are, whenever they need it, without any financial hardship. That is the core point of the UHC. And to answer if we are ready or we are not ready, and what are the challenges that we are facing right now, it's a little bit tricky. But I will tell you what is the situation in the country and where I've worked in the field and what is happening there. So when I think of the ways to implement UHC, I think I can't think of a better solution than technology, connectivity, and data to reach more people. And right now the situation is very improving because most of the hospitals have digital infrastructure. We've seen here some of the panelists are having solutions which include electronic medical records and some of the things of alike. And also the connectivity is very, very good right now. Most of the parts of the country have internet access. And also, we have a very good digital literacy among the population. People know how to use applications, people use websites, they make orders online, they make consultations online. So right now is the right time to start, I think. Despite the challenges that we are facing right now is the right time to start, so that when we're actually ready, we'll have somewhere to refer to and actually make progress. However, though, I have a few recommendations that I have seen in the field. Like last Monday, we had a meeting with a supplier of pharmaceutical products who is having a chain of pharmacies. And he wants to connect them with the central pharmacy, and they'll be ordering from it. So we had to take a look at what he's having right now so that we can improve and make it better. So what we saw is that in the categorization of products is that that system allows him only to categorize pharmaceutical products as medicines and cosmetics. So anything which is not medicine is categorized as cosmetics. So because of that, you find the baby diaper is categorized as cosmetic. So what I want to say is the quality and the integrity of data is very important. You could be feeding data into the platform or system, digital system, but then it is misleading yourself to make wrong conclusions. So if you're categorizing baby diaper as cosmetics, in the end of the day, you'll say that cosmetics are the fast-moving products, but in reality, it's just the baby products. So we have to look at the data quality and data integrity, but also the data interoperability. I mean, the systems should be able to communicate to each other. These different systems in different hospitals or departments should be able to communicate with one another. So I think there's a need to standardize them and make sure that they communicate with one another. But I think the challenges can be overcome, and we can make progress.
And what can you say about the policies? Do you think the existing policies are conducive for you to do what you are dreaming to do?
Yeah, for us, I think the policies are what is the correct word? They're making progress, because myself, I had a chance to work at the Pharmacy Council. The Pharmacy Council is the body that regulates the profession of pharmacy in our country. So you can't be a pharmacist, you can't sell medicines without have authorization from the Pharmacy Council. And when I was starting working there, I was actually a student in 2019, I think. I was a field student there. And when we were there, there was no regulations for online pharmacy. So if you want to maybe sell medicines online, you can't do it, not because you don't have a system, but because there is no regulations. There's no rules to play the game, so you can't operate. But right now, as I speak, there is a draft for online medicine purchasing, which is being prepared, and it's waiting for the minister to sign it before it starts operating. So I'd say the policies are not yet there, but I see the progress firsthand.
Okay, good to know. Now I go to Ade. You can add, but in addition to that, I understand, and you just presented there that you have your system what government and faith-based and private facilities, but I understand, and we were talking at the backstage, even the system between the government facilities which you provide, they don't communicate. What are the challenges which results into that?
Thank you so much. The one that John was answering, I find that I can think quickly two challenges. One challenge is the absence of policies that will attract such an opportunity to happen. And two is absence of harmonization. Because when it comes to technologies are already there. What do I mean by that? My HI here creates a patient. When a patient arrives at the hospital, our systems are speaking, so patient just put a finger, so all the medical records, the demographics, comes automatic to the EHR. Patient receives care. Unfortunately, this patient is hypertensive. Then patient goes home. Next month, patient just wants refill of medication. So he just call after call. After call, speaks with EHMS. Doctor can see the past medical records of this particular patient, what needs to be refilled. Doctor orders. The system speaks with PharmLink. PharmLink delivers to a patient. Everything is here. What is missing again is just the policies are not there to allow that, and also the harmonization so that it can happen, because the transformation can happen. I remember one company is called Nike. They call it just do it. I think that's what we need to do it. We just need to move towards making that happen. The same thing happening to the question you just asked me. It is true, there's a challenge whereby the systems are there, but sharing of records is not there. That at the level of one provider to another. But of course, I'm also aware there are some hospitals, even sharing of records within the hospital itself is kind of difficult, but that's because of the system itself is facing challenges. But as far as, at least to the our concern of EHMS, we know we have done that. We have evidence for that. Mohammed is one of my people that can evidence from Mnazi Mmoja. Within the hospital, records is being shared. But the thing is, what happens to a patient who comes away from Mnazi Mmoja to be referred to Mnazi Mmoja? That's where we talk of the data connectivity. By that time, when a patient arrives, medical records can be consumed from a lower facility to a higher facility or vice versa. The thing is, we are missing the policies that allows that. That is one. Two, reluctant, I can also say is another challenge by the health providers to accept records from a previous visit of a patient for a number of reasons. I've seen some of them saying, I don't trust the previous full body picture. I don't trust the previous x-ray. I don't trust the previous ultrasound. I need to do mine to ensure myself this is the correct diagnosis. That could be one of the reasons. But another reason is business. There, they've done their 15,000 for x-ray. What about my 15,000? That comes to issues of policy. Now, when it comes to UHC, if that is not taken care of, UHC is facing the challenge to collapse due to too much financing factor, that the same patient receives the same medication, the same diagnosis, the same treatment across different hospitals, increasing the burden of the payer. While the same records, if used, some of these diagnoses, we're exposing patients to these, for example, x-rays. People are being exposed their body to those rays and stuff. So by doing that multiple times, we are risking the natural health of a patient, but also the issue of cost. So to me, I think it's the policy and the harmonization that is continuing to hinder us from moving forward. But as far as technology, I know the technology is here. We, as the ICT background, we have capability to do it. At some level, we have proven that we've been able to deliver that, and we're just looking forward now for the next steps so that we can connect these different components to work one unified. At the end of the day, we create one patient, one record across the country. Thank you.
Thanks, Adelaide. You have spoke about the UHC, so I'll go now to Shilton. One of the experience when we were piloting ICHF in Kilimanjaro, at least every week I was receiving 5 to 10 calls of people asking me that, can we send you money so that you can ask people to go and enroll our relatives, our parents, our uncles who are in the rural areas? Why? If you send them money, they won't pay premium. They use the money for other things. So we want to enroll them directly through you. So here you are, Shilton. You have a solution, but we haven't heard your solution being used. Can you tell us what are the challenges?
Thank you so much. Hopeful, I'm needed to start the first question that you asked me. Yes. So first of all, what I can say that at least society, the consumer, people who we are targeting or we need them to buy insurance, they are ready. Because every day in daily life, in last 2 months, my friend's wife died just because he was paying for her treatment by using cash, and the bill escalated, and he could not afford to pay more for what, so that he took her to home and continued to take the pills so that she can get well, but she ended up died. So the society is ready because of these difficulties they are facing every day. But what I see, the government play its role of creating the plans, roadmaps of where we want to go. But the problems start with these government institutions who have mandate to execute the plans, they overlook the role of private sector. Because all of us here, for example, my brother, Mr. Adelaide, has been operating EHMS, he said, for more than 10 years. How comes if you operate in this field for 10 years and his system is not ready niches or integrated with the government system? That means there is a problem somewhere. And also, on insurance side, in order to make the insurance plans, you need data. And data of 10 years ago and data of today is different. In order to make informed and more current workable solutions, you need current data. So there is still a problem on policy of who owns the data, who is a custodian of the data, and how to use the data. And also, when it comes to my part, insurance regulation, still it's good, but not supportive to young people like us who came with innovative solution to make a real impact. Because to be honest, what motivational speakers or people say that you can start a business without capital, but it does not work on startup and health insurance sector. To get a license by itself, it's not easy. And after obtaining the license, you need the money to do the operations. So you need also the right capital and the investment to support this innovation until the day that it matures and it became big and even be profitable. If you ask each other, if you ask Mr. Adelaide and Corinne, I know now we can understand why they all have more than 10 or 15 years experience on the field. Yes. And coming to answering.
Oh, thank you very much. I'll come back to the issue of regulations not supporting innovations. But before that, I want to ask now Florine. Florine, I understand from the literatures, the system of health insurance in Switzerland is more or less the same like in the US. They depends on private health insurance. However, the one in Switzerland is more efficient with less costs, and this is somehow mostly due to two things: using of the family doctors and telemedicine. So you have the solution for telemedicine in Tanzania. How are the existing policies in Tanzania support telemedicine? And the way you see, as we are now going through developing a law for mandatory health insurance, how do you see telemedicine as being featured in that development of health insurance in Tanzania?
Thank you very much. I think starting with the issue of the police, my colleague have touched base on the issue of police. I think we all face the same challenges because telemedicine, it's the same application of technology in delivering the service, the health care. So the players, we are all players here, coming from different angles, each addressing from a different angle. As Afshikol, we are focusing on telemedicine. I remember when we started as the matter of police in relation to what we wanted to do, because when we started, we had a physical call center that we had, and we approached the Ministry of Health to give us an approval. By the time when we went, they were not ready to accommodate such a setup. But then, in general terms, the police were there. So the willingness of the government in terms of formulating the policy is there, but the policies are not complete or sufficient in terms of specificity. They are kind of generic, so when it comes to application to some areas, then you might get some challenges in applying, and that can stifle the innovation and development. So the way we see the government's willingness is there, but I think we need to move together first, because what I can see on the other side, innovation is moving far more quicker than the policy and regulation to support the innovation. That's what I can say. In terms of insurance, how can telemedicine support or help the development of health insurance? The way we view it, telemedicine is we are moving from a physical to virtual provision of the service. So basically it's changing the way the service is provided. What is the implication? The impact is on the cost, because when you apply technology, you have low cost. You can use more technology, so you save on the manpower in terms of human capital. So also the physical infrastructure you save. So the model of telemedicine, as you said, will help reduce the cost overall, both to the insurer and to the beneficiary. The insurers, what is the benefit? The benefit is one of the key elements in terms of the cost is the OPEX that comes from the consultation services that the patient goes. So if you have a vehicle or telemedicine, basically you don't need to go to the hospital, waste time, go see the doctor. At the end of the day, you are told, like, actually, you are not sick, you are tired, it's because of fatigue. Go and sleep, take some 2 days off, and you'll be okay. And actually it turns out to be okay. So you have wasted time, and the physical consultation is expensive. If you go to the best doctors in town, Dar es Salaam, it goes up to $70 to $80 per consultation, which can only take 30 to 40 minutes from the best doctors. But from Afiacol, 15 to 30 minutes, 3,000, you save the costs. The implication is if you call live, online, you will not go to the hospital. You will save time. If you're using the insurance, you will not transfer unnecessary OPEX to the insurer. So there is beneficiaries to both parties. Thank you.
Thank you very much. A very important point you have raised. I think it's time now for our schemes. It's surprising that even in private insurance schemes, which we think are very innovative, still do not include telemedicine in their package. So before I allow some contribution from the audience, so I have a question to you, Zamaradi. Can you share a few examples of the solutions PharmAccess you have been working on to demonstrate the role of connectivity and data as a way to achieve UHC?
Thank you, Dr. Harry. But before I share, I want to add to what Mr. Mudamba was saying in terms of the impact of policies in implementation of these initiatives aimed to improve connectivity. So you spoke about the impact of policies at that level, but there's also the impact of policies at a mid-level, I can say. So currently, we are at the discovery of one of the projects we are planning to implement in Kilimanjaro. So just looking for information. What are the problems? How are we going to address them? How are we going to implement the solutions and so forth? And surprisingly, one of the risks that we are planning to address is in relations to NHIF policies. So we are working with NCD patients, and they are saying that currently they're accessing services at a district hospital, but unfortunately, there are some medication that this level of facility are not allowed to dispense, to prescribe. So they have to go to this facility to access some services, but then they have to travel to another facility to collect some other medication. And you can imagine with all this, how complex this is, we are going and we want to introduce a service saying people should access care at community level, at dispensary level. But now you have an insurer who is saying some of these services you cannot even access at district hospital level because of our policies. So there is a huge impact of our policies at national level and at organization levels that are impacting the way we want to implement connectivity for healthcare. Coming to your question, what are we doing as PharmAccess, some of the initiatives? We have quite a number of them, but if I can share one or two. So one of them is remote care for NCD patients that we're implementing in Zanzibar, and we're also planning to start implementing in Zanzibar, in Kilimanjaro, Siha. So basically what it means is right now patients are going to healthcare facilities for all their services, but we are moving some of these services to community level or to dispensary level. And for us, dispensary is still level, but because most of the dispensary are at village level and they're within walking distance. So basically the NCD patients can go to these points of services and they can get their medication at these point of services. They can get their measurements taken, but they can also access health education. Meaning now if they need to go to a healthcare facility, it's only during referrals. So people are staying home and accessing care at home with a lot of benefits for patients, including saving costs on transportation. In some areas, people are paying upwards of 10,000 to travel to access care. And if you go to a healthcare facility and they're out of stock, this can mean 2 or 3 visits per month. So that is one what we are doing, but we are also doing something in relations to data portability. I think my fellow panelists have touched on it. So what we want to do is to ensure that when a access care at any point of service, be it at community level, dispensary, district, even zonal hospital, data can freely move between these healthcare providers. So if you go to a hospital, your doctor has access to information even from 5 years ago, from 10 years ago. And when this is successful, it means doctors will even have access to information from the time someone was born. But also, if someone accesses services at a referral hospital and they need to just manage their complications, they are most likely doing that at community level or at lower level facilities. So we also need to make sure that data moves to these lower level facilities so that we can facilitate patient management. So those are some of the 2 initiatives that we are doing, but if we meet again next year, there will definitely be more.
Thank you very much for that. So I'll now open the floor. If there is anyone who has a contribution or question, I've seen 1, 2, 3, 4, 5. Ushers, if you can help me. Okay, we can start there. Dr. Isaac, then behind there. Then I have 1 and 2 in front. And then we'll go another round.
Thank you very much. Congratulations to the panelists. I just have 2 points. They're not really questions, but rather experiences. I'm Isaac Maro. We have what we call Afya Check Community Outreach Programs, which is the largest outreach program in Tanzania. We have been going different areas, and we just come from Zanzibar. One thing that I've been noticing all this time is we are very late in terms of the connection between the data we have, which represent the need we have, and what we do to our people. There's a very big disconnect. And this somehow causes a lot of, I think, unnecessary mzigo. Mzigo is, it's a lot of work for the government. Like resource mobilization, resource utilization is not really 100% connected to the need of the people. There's a very big, I can say there's a very big gap between what the government is doing in terms of resource mobilization and resource supply and what is needed on the ground. Currently, we really do not have a data on the prevalence, exact prevalence of NCDs in our country. We know that currently there's a survey that's going on. And we find people who are really at the lowest level of the economy with the highest prevalence of NCDs, which needs a lot of money to take care of. And
1 minute. Summarize in 1 minute.
In 1 minute, okay. I wanted to congratulate AFIACOL and PharmAccess because AFIACOL has really brought a solution. One of the biggest and I think very effective solution is the ability for a person to make a call and have a solution in hand. I think you're doing something very, very important. We can talk of internet, we can talk of all this technology, but people that are on the ground, they do not have access to the internet. They have the mobile phones, and they do not have internet access, but they can make calls. So I think that for today, I think the biggest point that I'm taking is people like AFIACOL and people like PharmAccess should be given bigger support so that they can really reach the people that are there on the ground, using the simplest of the technologies, using the simplest of the solutions that are local, that you can get to a person who is in Moshi, Vijijini, who can access a center where they can get solution for their NCDs. I think that's the only way we can make this work, using the data that we have. Thank you.
Thanks, Isaac. I have a gentleman with a white shirt there, and then a lady on the left, then 3 will be that side, then we'll come to this side.
Thank you very much. I have a comment, rather, not a question, due to the interest of time. I think to achieve your vision, your dream, Dr. Barrow, where a client can be identified and can view the medical records, can be accessed from each point from within and between facilities. I think it has to do with the solutions, the digital technology itself, the innovation that we are bringing, considering the operating environment. For instance, in Tanzania, where we have more than 80,000 facilities, and 80% of which are within the rural area, where there is low resource in terms of connectivity, power, literacy, and even in most of programs, most of our population are within the rural areas. And even with, to achieve your vision, you want from the community, there must be a connectivity or the sharing of information from the community to the facility. So I think the way these solutions have to be designed, they need to take into consideration of the operating environment, where the solution need to take into consideration that it has to operate where there's low connectivity in terms of data, there's low power, there's low literacy. The ones who operate the solution should provide a guidance to whoever is operating to achieve that. Thank you.
Thank you very much. To the lady there with the blue next.
I would like to thank the panelists for sharing your question. Thank you very much. The question is on security, or about data talking, which is very good, but how do you ensure security and confidentiality? I'm not ready to share my card information and also my health information with anyone unless they need to know about it. So how do we ensure that? And also something else, how does medical examination come in? For example, with AFIACOL, and I'm not sure with also maybe Zamaradi. Also, AFIACOL, how many specialists do you have at the moment? Thank you very much.
Thank you. Okay.
Thank
you have hijacked.
Sorry.
No, it's okay.
Yeah, I have a question for Florin. So the statistics that you shared are quite impressive, and I think it alludes to the existing need in the community. I'll be curious to understand how is the design process inclusive of the people's reality experiences as they experience and interact with this platform, just considering how important it is so that we have a really good tool that is inclusive of their unique experiences. And also, how do you monitor the quality of the services that the people receive? Thank you.
Thank you. I think there was one in front here, right? Okay. And then the last one will be there, and then we'll allow our panelists to respond.
Thank you very much. My colleagues asked most of the questions that I was wondering on the AFIA calls and the community level healthcare giving. How do we follow up on our patients? If a patient calls, and most of us know that most patients lie, especially on the phone, how do you ensure that this patient got a certain service or their vital signs checked? And how do we follow up? Do we link them with the community health workers that we are planning to reinforce and use, or how do we monitor them? Also, on the data connectivity part, what app or strategy are you trying to put in place to make sure that our systems are linked in relation to the EMHS that has been around for years? They have been facing challenges to connect within a hospital. How are you going to do this through the whole country? Thank you.
Thank you. Okay.
My question is on the equity concern. So I want to know, how can digital healthcare initiative ensure that the vulnerable or underserved population benefit and don't get left out? For that I mean population like homeless, low-income earners, children, adolescents, elderly population, people with disability, pregnant women, and the substance use patients, and the prisoners, the rural and the remote communities. How can the digital health initiative ensure that those populations don't get left out?
Thank you. Last one from that side, and then I will allow panelists, then we will have a second round.
Thank you very much for very interesting presentations. My name is Karin Wiedenmeyer from the Swiss Tropical and Public Health Institute in Switzerland. I have two comments or queries. One relates to data protection. I think that has been mentioned already, patient confidentiality. With these, the connectivity, this is a very big and very important issue, legal and ethical issue, how this is going to be handled. And the other question is about patient outcome, just thinking about or referring to telemedicine. You know, a medical doctor or a health professional may advise a patient on the phone or on whatever means you have to communicate on Zoom about a diagnosis or what to do about a certain condition. How do you assure the quality of the health outcome, of the patient outcome in general in this way? Thank you very much.
Thank you. And I also have one question from those who are following us via Zoom. It's also related to the quality of data, like how will the facility trust the data which has been shared from the other facility? So I will allow the panelists to respond. So I start from Modamba's side, and then anyone can contribute coming this side. So welcome.
Hello. Okay, thank you. We'll start from the last point raised, and then I'll go on the reverse order on the issue that were raised, referring to AFIACOL solutions. Starting with the issue of the quality of consultations and the outcome of the service. How do we ensure that? As I said, right now, what AFIACOL is doing, we are providing consultation service via mobile phone. The professionals that we are doing is that are qualified medical doctors in Tanzania. Those are the people that we work with us. Basically, what we are doing is we are transforming from the physical to virtual. So the manpower we are using is the same as you would find them in the physical hospital. So yes, there is some way that we have to observe the way we provide service is different It's based on technology. So our staff are trained on how to provide the service, the consultation via the phone. I agree, and at the moment, the quality of the service depends also on the kind of technology we have. Right now, to start with, what we have done basically is we have started with a basic phone, not a smart. Yes, also considering we are using also smart phone users, but if you check the mobile penetration in Tanzania, and what we are focusing on is the mass, the majority of the people in the village. So in terms of roadmap, we will scale up from the basic phone that we have based on then move on to the smartphone. We all understand that if you use smartphone, you have advantage to collaborate the information that you get from the patient when engaging and getting the information, taking the history. So right now, we are using the mobile phone, and we have trained professionals how to engage the patient when providing consultations to get as much information they need to be able to provide the consultation. What we do, if we realize the issue is serious, then what we do, we refer the patient or the individual to a nearby facilities. Everyone is talking about data, connectivity and data. You have connectivity, you don't have data, you don't have business. So for us, we value data, and that translates into data protections. So ensure that we deploy and use all the necessary measures that are deployed in the ICT environment to make sure that they are protected.
Thank you very much. I'm told that our time is over, so if I can allow 1 minute for everyone. 1 minute, please, for others. Shilton, if you have anything, 1 minute. Okay. Adelaide, 1 minute.
I can just add on the issue of data protection in terms of the rights of a patient to have total control of in terms of who they want to share their records with. So what we have done, for example, in EHMS, is the deployment of the bio features in the system, whereby on patients' arrival or when they want to transfer their records, patients, they can allow that through either use of fingerprint or facial recognition. We have already done that with NHI provision patient visit for verification and authorization with NHIF, and the same will be done when a patient accepts their medical records to move to a particular clinic or particular doctor. Then a patient will authenticate that to allow their records to move. Thank you.
Thank you very much. John?
Yeah, thank you very much. I'd like to respond to a question about how do these digital platforms ensure that we don't leave behind the underprivileged people, the homeless people, the elderly and everything. So this is actually the main goal of UHC, that everyone gets access to healthcare wherever they need it, and without financial hardship. So these underprivileged people is actually the goal of UHC, to reach them. And if you look at it overall, there are a number of components that need to be checked before you achieve UHC. You need to have trained personnel, you need to have good services, population should be covered, financial and stuff like that. So I think it's us and the government to make sure that in each and every component that we have a digital solution that makes things easier there. Like for the issue of consultation, you have AfyaCall, you have EMR for electronic medical records, you have platforms that provide medications to people at appropriate places and stuff like that.
Thank you very much. Zamaradi, to wrap up.
Yes, I think for me, I will leave it on a higher note, and to add to what Dr. Isaac was asking in terms of data use, we are quite behind, So for me personally, I see it as a journey. It's more of a process. So we started with data collection and very successful with data collection. Probably we have overdone it a bit. We have a lot of data collection tools at facilities. Now, if you look at the current trends in the country, we have data analysis interventions and initiatives in the health sector. We see a lot of slides, a lot of presentations on data analysis. I think a few years ago, it wasn't easy to access NHIF data. You actually had to go physically to NHIF. You had to people to access. But now, if you go, the access NHIF. So I done data. We are now doing data analysis, and definitely we are going to get to data use. So, thank you.
Thank you very much. A round of applause to my panelists. So that marked the end of our session. Thank you very much, all of you, for attending and those who were following us through Zoom. We are looking forward to work together to achieve UHC. Thank you very much, and thanks, panelists.